Welcome to Like-Minded with Dr. Patrice. Each episode, we'll sit down with different types of experts and unpack the role of mental health in our day-to-day lives. On this episode, Dr. Maria Uloko and I will dismantle the myths, misunderstandings, and medical gaslighting that too often define the conversation around menopause and women's health. From the hormone shifts no one talks about to the care options some doctors won't even mention, this episode is all about reclaiming agency, breaking stigmas, and spotlighting the science behind aging bodies. Whether you're approaching menopause, already in it, or just want to understand how women's health has been systematically overlooked, this conversation is for you. I'm joined today by Dr. Maria Uloko, who is an internationally recognized sexual health expert and founder of MUMD Sexual Medicine Beverly Hills and Vulva AI. Known as a sexual health Sherlock, she specializes in vulvar and menopausal care, as well as regenerative treatments for erectile dysfunction. She has trained over 600 physicians globally and lectured at leading institutions including Harvard, Yale, UCLA, and USC. Her groundbreaking research, especially on clitoral nerves, has reshaped the field and has been translated into more than 10 languages. Featured in the New York Times, Oprah Daily, Forbes, and The Colbert Show, Dr. Uloko is a passionate advocate for closing care gaps in under-researched areas like vulvar health. Thank you for joining me today. It's so nice to have you here.
Thank you for having me. I'm excited to be here.
So, Dr. Maria, I want to understand what inspired your journey into this industry.
Well, I'm Nigerian, so I didn't really have a choice.
So you had to be a doctor.
It was sort of engineering. My life has been, I would say the word that describes my life best is serendipity.
Mm.
So my family was one of the first families that got a visa when the visa lottery program opened in 1995.
Mm-hmm.
And through a series of, again, magic, we ended up in Kansas City.
Okay.
And in Kansas City, there is a 6-year program where you start right out of high school, go straight into medical school. So at 17, you're seeing patients and like learning all about the human body. And early on, I knew I loved helping people,
Yes.
like even outside of the
Can we go back then? What was that like as a 17-year-old? Let me tell you what's the matter with you.
It was wild. It was wild. As I reflect back on it, I think of two things. I think first and foremost, I think it was the right thing for me.
Mm.
I did not come from a family that had doctors in the family. I was the first doctor in my family. And I also didn't really come from a family where things were laid out for me. Every single thing, every success that I had was really me just kind of figuring it out.
Really?
I had a lot of great friends that were like, hey, girl, did you study for the ACT? And I was like, I'm sorry, the what? I was like, okay, cool. I need to learn, study for the ACTs. Just constantly failing upward in a way of just like, oh, I didn't know. And so just constantly having to figure it out.
Yeah. But that's so funny. I mean, even, that idea of like failing upward, not really, because you were surrounding yourself with people who, wanted the best for themselves, wanted that for you too.
Yeah.
You know what I mean? And that there is something very special about who you're around, who you make company with.
Yeah. So just having those people in my life. And then two, now I look back on it, and I realized that, at 17, you're learning, you're growing, your brain isn't developed, and yet you're holding really heavy conversations. You're holding death. You're holding life.
Yes.
You're holding the fate of another human being's life in your hands. So I think it forced me to grow up really quickly, and it forced me to mature in ways that I don't think a lot of my counterparts did. Even when I got into residency, I remember being so embarrassed or a little low key, like a chip on my shoulder that I was so much younger than everyone. And I wanted to prove that I was, I belonged there. And I realized because at 17, I was holding so much and doing so much, I was way more mature than I was the people there.
Absolutely. Because the world, is asking more of you and you are able to deliver on that. How did you, or do you feel like there was a need to, how did you take care of yourself? I mean, you're 17, holding all, you're saying literally life and death situations.
Yeah. So I don't think I did until my residency. Until 4th year into my residency. Okay. I luckily had a really amazing, solid group of friends in medical school. Shout out Tau Nu Alpha. And this was a group of 12 women who we just kept each other grounded. And we went, and a lot of big life changes happened, and we held each other in those spaces. And I think that we were also goal oriented, that we were just like, put our heads down, get the work done, grind. Yes. And then it wasn't until my 4th year of residency where grind wasn't working anymore.
Why? What was happening?
Yeah, you know, it was, I in every space I've been in, I've been the first.
Okay.
So I was the first Black person to graduate from my medical school and go into urology. I was also the first Black person to match into the University of Minnesota, and also to graduate. So
really,
all of those things sound like an amazing accolades, but actually it comes with a lot of trauma.
Being the first is difficult.
It comes with a lot of trauma because you are now either a scapegoat, you have a target on your back, and there's also always the like, well, we let one in and she has to be perfect, or we're not going to let anyone else in. So I had a lot of pressure on myself, and I'm super competitive, so I was ready to take on that pressure. But I realized, though, that without addressing other things, without addressing the mental health aspects of all of that, what that can take a toll on your soul, on your body. It wasn't until my 4th year, and I still remember Dr. Jane Lewis, who is one of my dear friends and mentors now. She's our pediatric urologist. We spend 4 months with her, and she literally just becomes your friend. And I was sitting with her, and I was just so not in a good place. I was like, I have a year and a half. And then when I'm done, I'm going to go and I'm going to go get therapy.
Yeah. Well, so when you were saying you weren't in a good place, were you like burnt out? Were you like, what were you noticing in yourself?
Yeah. You know, living in Minnesota, I was in Minnesota for 5 years. Okay. And I was there during George Floyd. I was there during the unarmed Black men being murdered. There's just a lot of racial issues that not a lot of people understood. It was the first time it was the first time I experienced racial gaslighting. It was just living in this kind of like, I call my experience there like the plot of Get Out. I felt
really?
Like for 5 years I was living that plot of Get Out. I still remember going to see Get Out and crying because it was the first time I felt seen.
Wow.
And so when and then on top of that, I'm working 120 hours a week.
Yeah.
And so it was more so, honestly, I can work all day. I'm Nigerian. I'm a workhorse. I'm a prior athlete. Like working isn't hard. It was more so the like psychological and social trauma that I was experiencing, and no one was able to handle it.
Well, and it's probably difficult for other people to understand that part of it. You know, you can say working 120 hours a week and people are like, oh wow, that's a lot of work. But then that emotional load, that social, that psychological load on top of it is the exhausting part. And also because you then have to try to explain it to people if you bother, you know, trying to explain it to them. So that's a lot of the work right there.
Yeah. And I still remember Dr. Lewis starting her rotation. Our 4th year, she was known as very much a hard ass. Like, you don't come into her OR unless you come correct or get the fuck out, dare I say. And so I remember the first day, like the night before, I was studying so much about the patient, about the case, like the history of the case, the history of the mom. Like I could tell you the time of conception of that kid. I was ready to go. I was ready to go. I showed up early. Like I made sure that like all her table was correct. I just was doing all the right things as a resident. And she walks in and I was like, oh, okay, let's do this. And she walks in and she just sits down and she's like, holy shit, Maria, you're a Black woman in urology. How exhausted are you?
Wow.
And that was the first time that anyone had ever said the quiet part out loud. And I wasn't ready to answer that question. I was like, shoot.
I know this case, but I don't know myself.
I was like, bad. It's bad. It's really bad. And so we spent 4 months just really unpacking that and just really her holding me and showing me and just even giving me space to share my experience. And she was the one that really encouraged me to start going to therapy, to start really handling and addressing not only the wounds of that 5 years, but also the wounds of starting medical school at 17. We really didn't have mental health support. And unfortunately, a lot of my classmates ended up dying from, drug overdoses, like just real mental health, struggling with really severe mental health issues. So when I look back on that time, I am so glad I did it, because I don't think I would have been able to get into medical school otherwise. Because again, I didn't have that structure that a lot of people did. And also, I do not recommend it for a lot of people unless you have a really strong support network like I had, and I still have. I still am in constant contact with those women. And actually, my biggest thing is that I got a lot of those women into therapy themselves, right? And it all came from my mentor, Dr. Lewis, saying, like, she literally said, cut the shit and go to therapy.
Yes, but someone's seeing you. I think that sometimes, when I've had clients who are like doctors or like in very high-powered careers, people see the success, but they don't see necessarily what it took to get there. Or people aren't always as open to hearing about the struggles behind the scenes, right? Because someone's looking at you like 17, like this, and you're like, yes, and all these other things, all these other pressures that come with it. And I think sometimes maybe we're also hesitant to share the not successful part of it or the struggles, right? And people maybe are less likely to want to hear them as well.
Yeah. Oh, I'm very open about about it all, because I think her being so accomplished and her saying, I went to therapy, gave me permission to say, okay, this is something I can prioritize. This is something that's not a stigma. It's not something to be embarrassed about. Because what we deal with in healthcare is not normal.
Yes, it's not.
It's not normal at all.
Well, and it's also not normal to have to deal with that, but to deal with that all day. But then also go back, what's your own regular life that is not about your patients, not about the people that you're seeing all day, but then to also try to have your own life that is intentional and that, welcomes other people in, right? That's another pressure on top of it.
Yeah, and I think if we don't talk about mental health in the healthcare profession, I mean, I think doctors have one of the highest rates of suicide.
Yes, they do.
And so that's why I'm so open about, everything. It's just, you gotta go through it you gotta heal it to feel it. You gotta feel it to heal it.
Yeah.
And if we don't start acknowledging that what we do isn't normal, and as someone that believes she is one of the toughest people she knows, I am also pride myself of being one of the softest people I know too, because there's actually strength in softness
100%.
and vulnerability.
Yes, and I think that sometimes, like we don't know that there's space for both, or that one is like a sign of the other, like, yes, you can be strong when you need to be, but I don't want to always have to be, sometimes I need space for both things, So, I think that's amazing. It sounds like that time with your mentor was really pivotal.
Yeah. It truly actually changed the whole trajectory of my life, because once I accepted that, I also accepted it made me start really thinking about what makes me happy.
Yeah.
And I think I realized that, becoming a traditional urologist wasn't going to make me happy. Like, it was just a job. It was, at that point, it was just a job. I didn't get as much joy out of it as my other colleagues. Like, they could talk like renal surgeries, like all day. And I was like, I love kidney surgery. I think it's very fun. But my excitement is,
I think that's a first on the show. I love kidney surgery.
Yeah, I loved it. But it was more so like, I liked the end of the surgery when we were done.
Oh,
I liked
the results?
Yeah, I love the results. I love the results, but I wasn't getting like the joy that I got to watch my colleagues get out of like all of it. And so then I started really thinking, okay, what am I, instead of chasing like prestige, because as Nigerian, I was kind of like conditioned to chase prestige, right? Become a urologist, that's super prestigious. Become one of, I'm 0.02% of Black female urologists. That's also very prestigious. I was like, you know what? I've chased prestige and I am unhappy.
Yeah.
Why don't I start focusing on my happiness? And so that conversation led me to start really getting clear, like start drowning out all the noise and start listening to like what my joy is. And my joy was sexual health and sexual medicine and having those really hard, deep conversations that can be really awkward, but then bringing people over to the side of joy. And then I also realized, who do I want to learn from? Because a lot of the urology is still very male. And so I was like, I started thinking about like, who my mentor wants to be is a mentor who I can actually enjoy having conversations with, whose life I want to emulate. And there just weren't a lot of them that I wanted to emulate their life. Like I wanted to be able, I feel like a lot of my colleagues, their kids never saw them because they were always working.
Okay.
Or
So like the balance was missing.
yeah.
Okay.
And so how could I live a full life? How can I live a life where I'm so passionate about what I wanted to do? Because I got to watch them. They were so passionate. I was just like, yeah, that's cool. But and then I met my fellowship director and mentor, Dr. Goldstein. And he specializes in comprehensive sexual health. And he was actually one of the lead researchers that took Viagra to market. We met at a conference and he literally just like turned to me and was like, I want to train you. And again, feeling seen.
Yes.
It was so validating.
Yes.
And then also he was in San Diego and I was living in Minneapolis.
So
I was like,
I'm from San Diego. I can see why you would make that decision.
And so I had
weather-wise, you're like, get me out of here.
Yeah, I had to do a site visit and it was 78 degrees in San Diego when I was doing my site visit for fellowship interviews, and it was negative 40 degrees in Minnesota.
My God, yes,
and I
there's
said,
no discussion.
I said, this is where I'll be.
Okay, so I want to talk to you about, because you've mentioned like that, the prestige and that, the pressure or like the maybe encouragement to chase prestige, and part of it being Nigerian. When you decided that you were going to focus on sexual health, like what were the conversations you had to have with yourself or with other people to say like, this is my goal, like this is what I want to move towards, and it's maybe you think it's prestigious, maybe you don't, but this is what I need to do for me. Like, what were those conversations like?
Yeah, actually, I still remember. So in most urology programs have, if you're going to do sexual health, you're going to do only men's health.
Oh.
And so
wait. Why?
Because urologists are known as the men's sexual health field.
Okay.
And in theory, gynecologists, like on the flip side, we think that gynecologists are the female sexual health.
Okay.
But we'll get into that.
Yes, please.
And so, when I was thinking about who I wanted to learn from, and these fellowships are usually just one-on-one.
Okay.
And so now you're like really deeply connected to one person.
Yes.
And I was like, oh, well, shoot. I don't think I would want to hang out with you guys anyways outside of work. And so I got very clear on what my values were, and then who I wanted to learn from. And I went from this mindset of, oh, I'm just so lucky to be a urologist. I'm so lucky that I got this opportunity. And it's like, no, girl, you worked really hard.
Yes.
And you now get to start making choices from a place of power and a place of prioritizing you, because you prioritize other people's wants, and look how unhappy you became. Yes. So in our claiming our joy, let's do that. And I got pushback too. Don't worry, I got pushback. Because when I decided I was going to do the Goldstein Fellowship, which is the Comprehensive Sexual Health Fellowship, where we take care of all genders. Okay. It's the only fellowship in the country where you also learn women's sexual health and vulvar sexual health. And
the only program in the country.
Only program in the country. And I still remember one of my big bosses came up to me and was like, "What are you doing? Why are you doing this? Like, this isn't gonna. It's like, this is gonna be career suicide for you. Like, it's not as prestigious as the other ones that I want you to do." And then, because this man likes to talk business, I said, "Okay, look, listen. If I only do men's sexual health, I only get one. If I learn sexual health for all genders, that's a constant referral pattern."
That's right.
And he was like,
what a good point.
Okay. All right, I see you. So I was able to bring him over. Okay. But it definitely, no one looked at that fellowship as this really prestigious fellowship. They were just like, okay. Because again, urology is such a small world and it's such a hierarchical world, and people have to kind of make their name.
I see.
And you then, this guy has a fellowship and he's trained all the next directors of their own fellowship. So he's prestigious. And if you want to be just like them, you go to that fellowship. And yeah, I was like, I'm not doing this. I was like, I'm off the rat race. Yes. I don't want to do this anymore. And I want to just do things that's going to chase my joy. So that's what I did. And leading to my joy has actually led to a lot of great things.
Yeah. Okay. So tell me about, women's sexual health, because I will tell you, and I think we talked about this before, Maria, like almost every other conversation I have with my friends, like we're all mid 40s, like, to early 50s, is menopause. Perimenopause, do you think this is a symptom? Should I try this? And everyone's just talking to each other.
Yeah.
And so I would really love to understand like what kind of things you're seeing as far as when women are thinking about menopause, but like also, like their sexual health overall, and like feeling gaslit or maybe feeling dismissed. Like what kind of things do you see in your work?
Yeah, I do a lot of research around education and gaslighting. And what I've come to realize is that, most doctors take the Hippocratic Oath to first do no harm. So they're not like every day, like, haha, which woman can I gaslight today, And so I had to come to this place and realizing, okay, this is a systems issue. Because like I said, I started medical school at 17.
Yes.
I know healthcare inside and out. Like, I feel like I still remember the Krebs cycle, like things like that. But I was like, wait a second, how did I just not know that there's actual physiology when it comes to the vulva? How did I not know that the vulva is actually directly related to the bladder? How did I not know that the pelvic floor is directly related to symptoms like constipation, diarrhea, pelvic pain, overactive bladder symptoms? There's this social contract that we all take when we go into medical school of like, okay, I'm going to jump through all your hoops. I'm going to pay all your money. I'm going to take all your tests, with the idea that I'm going to get all of the information that I will ever possibly need to be able to take care of a human patient. And I think the fallacy is that we get a lot of that information to take care of a male patient. And when I got into my fellowship, all of a sudden I'm learning bare minimum basic anatomy and physiology that I was like, wait, how did we not know this
Well,
stuff?
and if you're just learning that in your field, like imagine like the rest of us, like all the things we don't know about ourselves and about each other. Yes.
And I was so confused. I was so confused. And I was like, well, maybe it's just urology. Maybe it's just us. And then a lot of the patients, where I got really curious was listening to the stories of the patients. And so many of the patients had gone to their gynecologist, had gone to their primary care provider. Those were the two biggest access points. And they were told nothing's wrong with them, or they just have UTIs and that's just going to have to live with it. Or it's okay to have UTIs after sex. And then they would come to us in our very private bougie practice, and they'd have to pay out of pocket for me just to do a very basic exam and just like, you've got lots of inflammation. Here's cream. Yeah. And a lot of the patients were like, why did my doctor never see this? How did they not know? I've been suffering for 15, 20, 30 years. And, thinking about the curriculum I got in my fellowship, hearing the patient's stories of the consistent lack of access and medical gaslighting, it got me really curious about and going to the literature and seeing, okay, what do we know?
Yes.
And how have we assessed our comprehension? And if we look at a lot of the studies around the comprehension of women's health, they're deplorable. It's bad. It's consistently bad. Every study shows that we are not comfortable doing pelvic exams. Every study shows that we're not comfortable talking about sex. Every study shows that we are not doing a good job. And yet, despite those studies showing that, we as a healthcare system, as a medical education system, are not changing the curriculum. Currently, only 50% of medical schools even require a sexual health curriculum.
Wow.
And if you're going to get that, it's going to be skewed predominantly towards men. And so that's on the medical education side. And then from the then you split them into gynecology and urology. Urologists, we cannot leave training without also having a component of comprehensive sexual health too. Okay. So infertility, menopause.
Yeah, I want to talk about that too.
The whole scope and gamut of men's sexuality. And for many curriculums in gynecology, they don't really focus on quality of life. They focus on pregnancy. Yes. They focus on surgeries and cancer and really things like perimenopause, menopause, pelvic pain, orgasm dysfunction, sexual dysfunction, arousal, desire. It's not in their curriculum. Yes. It's seen as frivolous for a lot of people. And so a lot of gynecologists and a lot of people leaving these trainings, they don't know that they're not getting it. They are just being taught what they think is important. And then they get into the real world and that patient's saying, oh, it hurts to have sex. And you're like, this isn't in my textbook. I don't actually have a framework for it.
Even to your point, even though they're not purposely like, okay, I'm planning on gaslighting you necessarily, you're being told what is important by what you learn. And if you're not learning it, okay, maybe this isn't something that I need to get comfortable with talking to clients, because maybe I don't know what my answer is going to be.
Yeah.
So maybe I'm not going to broach the subject with you, and you're uncomfortable with it. I'm uncomfortable with it. So let's just ignore.
Yes.
And I think that seems to be kind of what's happening. What's your take on why it's so minimalized? I mean, besides like, the patriarchy, like what do you think it is?
I think it's the training. So one of the fascinating things is that OB and GYN are two very separate specialties. And back in, I think in the 20s, 30s, they decided to combine the specialties, but they didn't extend the training. And so because of the lack of extension of training, there's whole chunks of their curriculum that they're not getting.
Yes.
The other thing too is the economics of gynecology is really poor. You're going to get a lot more reimbursement for obstetrical care than you are for gynecologic benign conditions. A lot of benign gynecology isn't surgical, and there is a huge pay discrepancy between urologists and gynecologists. So
tell me an example.
Yeah. So I, as a urologist, if I do a surgery on the vulva versus a gynecologist does a surgery on the vulva, I'm going to make more money because my lobbying group has lobbied for better reimbursement rates. There is so much inequality in the system. And the people that suffer the most are the patients. It's not that like gynecologists don't want to do this. They truly are overworked. There's a huge shortage of it. They're not being given the correct curriculum, and then they're not getting reimbursed well.
Wow.
And so when people are making decisions about what's going to be in the curriculum, they're going to try to think of the highest yield. Also, the litigiousness of childbirth is also, you got to make sure that you're really good at that before, someone having a little bit of pain when they have sex. It's like, which one are you going to weigh more?
Wow.
And so there are many gynecologists, it's not just me, that are speaking up about this too, about how they need to restructure the training in general.
Yeah, because then it just becomes like a cycle of people not having the training, not having the practice, not having the conversations, and then, people having their issues kind of ignored, or dismissed.
Yeah, it's not uncommon for a lot of people doing women's health after their formal training, they go out and have to get more training. That's why societies like the International Society of the Study of Women's Sexual Health, ISHWSH, exists. This is a organization that puts on conferences so that people can start supplementing what they didn't learn in school. But the thing is, you can't teach a whole gynecologic curriculum in a weekend.
No.
And that's not fair to patients. It's also not fair to those providers, because although they're getting some of that language now, some of that understanding, there is something about the art of diagnosis and seeing it and doing repetition, and then also being able to I was very lucky that while I was learning it, I got to go back to my my fellowship director and be like, hey, I have a question, or hey, I'm thinking about it this way. That's the process of learning medicine.
Absolutely.
And instead of doing that, we're just like, just gonna go to a course. You'll be fine.
Yeah, right. And the course not being part of the curriculum, not being something that is mandatory. It sounds like, also
exactly.
It kind of also highlights, okay, well, this is like a good to have versus a necessary thing that you need to understand about women. How do you think that affects how a lot of women navigate care? For a light question.
Yeah. I love that question. I think we're leading to, there's a lot of frustration. One of my superpowers in terms of how do I come up with research questions is I just sit and listen.
Yes.
I get to sit and listen and have people share with me their stories and their journeys to getting care. And it's rarely like, hey, I had this issue. Then I walked into a doctor's office and they totally believed me. And then I had really easy, accessible,
for me. Yes.
really accessible options.
It was great.
That fit into my insurance. Like, that is not the case.
Yes.
Oftentimes what's happening is that women and people that experience menopause or sexual dysfunction, vulvar dysfunction, if they even feel brave enough to go in, they report their symptoms and they say, wow, that sounds like a you problem. Because in my curriculum that I learned, that's nothing there. And that's where the medical gaslighting is. It's not that, it's not that doctor is like, can't wait for you to suffer. It's just like, oh, it's not in the textbook. So I truly don't know.
So it must be, it might be, just this singular issue in front of me and not an epidemic.
Exactly.
That's so interesting.
Exactly. And so then that patient, they have two options. They can be fully defeated and just be like, I guess I'll suffer.
Yeah.
And then their symptoms get worse and worse and worse. Or that patient's like, no, I know something's wrong. I'm going to trust myself and I'm going to find someone else. On average, if we're looking like just at pelvic pain, on average, it takes 3 doctors to get that first diagnosis. And oftentimes that diagnosis is wrong. 35% of those people will see 15 or more doctors. And this isn't just a small number. 1 in 4 people with a vulva will experience pelvic pain. 25% of people with a vulva will experience pelvic pain. And this is their journey. This is them having to piecemeal their care together. They're oftentimes going on forums like Reddit, like Facebook, trying to just like get information. They're going to Google. Google is wrong 50% of the time when it comes to women's health.
Oh my God.
They're just trying so hard. And then they end up at clinics where my fellowship, where, they're paying exorbitant amount out of pocket. And on average, it takes $20,000 for people to get a diagnosis for pelvic pain.
Well, and that's just not realistic for most people. So I think, you're imagining so many people suffering in silence or trying to get the answer. Friends, like, what did you try? What should I try? And, the blind leading the blind, basically, know? And, but I could, because that emotional part of like trying to be believed, right? That psychological part of trying to be believed. And then also just the logistics of, do I have the money? Is my insurance going to cover it? Do I have the time to track down 15 doctors? It's like to find someone who's going to believe me. Like you have to imagine that so many people are just giving up.
Oh, 100%.
And just saying like, okay, I guess this is a me problem.
Yeah, no, I have to make a PCP appointment. I haven't done that in 3 years. Like I'm just like, I'm my own PCP.
I don't know about the plan.
I literally am just to make one doctor's appointment. I'm like, this my whole year is ruined.
Right.
And so I can't, like, when I talk to my patients, I realize that getting a diagnosis is their life now. That is their entire life.
Yes.
And that breaks my heart because these are women, these are people that can contribute so much to society.
Yes, if they were freed up to...
if they could just get real, credible, evidence-based care. And one of the hardest parts about this journey for me is that it's really hard for healthcare providers to look at themselves. It's really hard for them to understand the impact of what we do. Because in theory, we all wake up saying, I want to help people. Yes. But until you actually start understanding the systems and how the system is failing us, we won't understand how we are then failing them.
Yes.
And so instead of saying, oh, wow, we need to do better, we say, well, that's a them problem, or we don't, it's just not something that we care about or care to learn about, and that's the stuff that breaks my heart. But that's also the stuff that made my warrior spirit say, okay, fine, you won't do it, I'll do it.
I love that. Well, it kind of makes me think, Maria, about like in therapy, when I see clients, they come to me with a challenge that they're having, and I don't necessarily anymore feel like I need to have an answer for you. I need to validate, believe them, right? And then like, okay, let's work through this together. And I imagine that so many of the people that you see also just need to be believed.
Yeah.
Like you're not, and just because you don't necessarily know how they're going to find a solution at that moment. You're there as a partner to them.
Yeah.
And sometimes that's like what we need for healing, because if you go through so many things of people being like, I don't know, I've never seen that before. Like, we don't have a solution for you. It's not necessarily that people need to know exactly what to do in the moment, but they do need to know that someone is with them on that journey.
Yeah.
You know?
Yeah. One of if you look at the treatment algorithm for many sexual dysfunction, the first and foremost is education and validation.
Yes.
And also, I'm really good at diagnosis. So, so I will believe you and we will get down to it.
Yes.
But that's also because my fellowship director, he retrained my brain. Like,
How so? Tell me.
I had to go from, because we would see, I would say we would see some of the weirdest, like most out there cases.
Okay. Like, give us an example.
Someone that has 40, 50 orgasms a day.
Okay.
Or every time they have an orgasm, they have excruciating pain that radiates down their thigh down to their toe. Just things that were just like, you're like, this is literally not in a textbook. I don't know how to fix this. And so instead of my first initial answer to be like, I don't know, I would then go to him and we would literally he's like, that's not an answer. You can't say, I don't know. You say, I will figure this out with you. I will work with you. I have never met someone that was more curious, more stubborn, more passionate about making sure that that person got the healing that they needed. And that to me was one of the biggest gifts I've ever gotten, because it, again, made me check myself of like, oh, wait a second. I'm also in that medical gaslighting. I'm also seeing that indoctrination of like, well, I've learned this much. I've now learned at least more than I did before, but because of my bigger book and it's not in there, it must be you.
Yeah.
And then he was like,
That's
our
not an
job is
answer.
always to stay curious. And so in that staying curious and staying curiosity has led to so much scientific discovery for me, for my patients.
Yes.
And it's just, I view difficult patients, difficult conditions as really fun. I'm like, oh, let's go.
Yes.
Like, it's not a you thing. It's an us thing. I will be here with you every step of the way.
Yes.
That is something I wish that we could adopt in the healthcare system. Granted, the capitalism of it all is you can't do this in a 15-minute visit.
No, you cannot. No, you cannot.
But that's why sexual medicine experts exist. But at baseline, we still just need basic anatomy and physiology and basic understanding of what happens to women and people with ovaries when they're not having babies.
Yes, right? Now all the rest of our lives when we're not actually
because there's
having a baby.
really easy solutions. And instead of just being like, yep, that's normal, lots of things are normal, but they're not acceptable.
Right.
And incorporating that into our general curriculum, like we could be saving so much money in the healthcare system. We could be impacting so many lives, and yet the curriculum hasn't changed. The AMA hasn't changed. ACOG hasn't changed. CREOG hasn't changed. And
what are all those?
So those are all the governing bodies. So AMA is the governing body of medical education, and AMAC. ACOG and CREOG are both governing bodies in OB-GYN. And so I've worked with a lot of patient advocacy groups of trying to get these organizations to also start taking these conditions seriously, to look critically at the curriculums that they have and actually start making change and reflecting those changes that is prioritizing these conditions. Yeah, you could, yes, they do have guidelines and stuff on their website. Cool. But if you didn't if this isn't even in your medical textbooks, your curriculum, first and foremost, as a standard, this is, again, a supplemental guideline. It shouldn't be supplemental. This should be foundational to our education. And so I'm just such a big believer that we can really change education for the better, which then downstream changes patients' lives for the better.
I'm thinking about the benefit too of of patients seeing you and like the research and everything that you're doing, like you as a person. Because so not long ago, I spoke at a maternal mental health conference,
Mm-hmm.
and it was largely about reproductive justice.
Mm-hmm.
And a lot of the time that we spent talking about things was about how people even get to a point where they can trust someone who walks in the room, right? To even tell you what's going on with me. And of course, we were talking about all the ways that like women's bodies, and especially like Black women's bodies, have been, exploited over the years. And so there is like a natural and I think reasonable level of distrust even to get there. And I wonder what the impact for people to see you. It's like I can understand where you're talking about, like where there might be stigma or where there might be shame or like a discomfort. And we're going to have this conversation anyway.
Yeah.
And you can do it with me. Like I just wonder about the power of that,
I don't think I fully grasped the power until I recently just came back from Essence Fest.
Okay. Yeah.
I was a vendor at a booth
Mm-hmm.
promoting my health tech company, Vulva AI, which is using predictive AI to mass train doctors and patients around vulvovaginal health and getting to diagnosis, getting to treatment quicker, faster, more accurately. And so we had a booth, and I was really just trying to like prop up the tech and like just like, guys, this could be your future where you don't have to guess. You can like use this technology, and you can become your own vulvar specialist because you're now empowered to make healthcare decisions. And it devolved into women just wanting to talk to me.
Yes, right.
And like I had so many enriching conversations. Like they'd sign up and then they would then wait in line just to say hello,
Really?
just to say
Share
thank
a
you for
story,
seeing us,
yeah.
share stories. Thank you for seeing us. And I was like, whoa, because I always, no matter what, I never really wanted me to be the product. I wanted to create something where you don't need me, where because I can't be in everywhere at the same time, but I didn't fully realize just how my approach to a lot of these conversations and normalizing it and making it fun and making it not scary and not shameful.
Because of who you are and what you've experienced, you're going to design a product that fills in all of those kind of awareness gaps, right? Like you're going to make sure that you're answering these questions that you've seen people come to you with. So even if you're not the product, but as the designer, that's, that is what really creates the mold, you know, for what needs to be out there in the world for people.
Yeah. I mean, I got so many hugs, so many amazing, impactful stories. Women would come back the day after just to give us a hug again. And I was like, oh my gosh, that feels so good for my, I have a very much an artist, squishy hearted soul. But yeah, it was
because,
lovely.
You were there talking about sexual health and so people could tell you their stories of maybe, I think you mentioned where someone had a hysterectomy that they didn't need, but also the other side of that, the pleasure part of it. So tell me about that, that it wasn't just tell me all the traumatic things that have happened to you, I'm here to give you a hug, but also let's talk about all the ways in which we can thrive in a different way.
Yeah. So one of the cool things I love about the work that I do is that we go all the way from pain to pleasure. So pain being the dysfunction, whether that is truly pelvic pain, recurrent UTIs, overactive bladder, orgasm dysfunction, arousal dysfunction, low libido. You come to me with those issues, we solve that, and we get you all the way to pleasure.
Yes.
Because there's an interesting thing that I've noticed when you're taking care of people that have been suffering for so long. Even when you get them past the biologic issue, you cure the biologic issue, there's still that psychosocial soul level barriers to getting to pleasure. And so I also spend a lot of time too on getting to pleasure because this is being able to take care of all genders. I'll give an analogy where, one of my favorite surgeries to do is a penile prosthesis, a penile implant. So that's for men, people with penises who have essentially end-stage erectile dysfunction, and they want to be able to have an erection on demand. And so it's a silicone rod that goes into the penis. There's this pump in the scrotum, and then every time they want an erection, they just pump it up, pump it down. Awesome. Amazing.
Pump it down.
Yeah. And so it definitely solves for the problem of ED, right? But one of the funniest things to me is that we would do this all the time at the VA, and we'd put in the pump, they'd heal 6 weeks later, and I'd be like, okay, well, like, how does your partner like? And like, my partner doesn't want to have sex. And I was like, then why did we do all that? Why are you were in pain. You were in so much pain.
Yes.
And so it was just like, these feel like really incomplete conversations. Like, I was like, yes. At this point in time, I feel like a mechanic more so than like a sexual health expert. And so that was one of the other big reasons as to why I wanted to also learn the female side of things, because the reason why they couldn't use their device is because their wives' like vulvas were on fire. They were going through significant menopausal issues. And so no one was managing that. And so we see the same thing on the women's side of things of like, okay, we take you from that biologic pain or whatever dysfunction that you have. But then because of the psychological, social, and emotional toll of living with that for so many years, how then do we get you to pleasure? And that's a whole different conversation.
It really is. I think, especially when you're just like, the goal is to not be in pain, right? And that's your sole focus. And then I think also, that some people just don't feel that they deserve pleasure, right? And they feel like that's something they have to earn. And having that conversation with someone who maybe doesn't even know that's what's standing in their way, or maybe their stigma, like, okay, I was raised to be like a good girl, and that shouldn't be. I have kids and I do this stuff, but like, pleasure is not even something that's discussed or something that is, I'm thinking is okay to be part of my life and, important to be part of my life.
Yeah. I love giving people permission to pleasure.
Yes.
I love it. I love it. I love it. I love it. Because when you see someone take ownership of their sex and sexuality and their pleasure, they show up better in the world.
Yes.
In every single capacity. Totally. I have had patients like go on and write like New York Times bestselling books. I've had patients like close like 9-figure deals. I've had patients build communities like in Africa. Like when you get people to embody pleasure, it causes ripple effects in the community and in the world. And I know it's the craziest thing, but I'm sure this is what an orthopedic surgeon feels like when he's the orthopedic surgeon for Michael Jordan.
Yeah.
Like I did that.
Actually, I don't think it's wild, right? Because I think that when we do things like that, like we're signaling to ourselves that I'm worthy of being taken care of.
Yes.
And then how you show up in the world is very different when you already have decided that you are worthy of this and you are going to prioritize yourself.
Yes.
Because then it gives other people permission to also prioritize ourselves, And so I think it's not crazy at all. Like it sounds, like you give people freedom to kind of, be able to dream. What else could I be doing with all this time that I've saved now that, I'm looking after myself? Or, not just that I'm not in pain, but also that I'm like actively taking care of myself.
Or I'm not having terrible menopausal symptoms. I mean, the menopause industry alone, and the impact of what menopause does to industry alone is in the trillions of dollars. Wow. Like, because menopausal symptoms cause such significant issues like brain fog, night sweats, insomnia, things that directly impact health and then also performance. Women leave the workforce right in their 40s and 50s, and that is costing businesses trillions of dollars. Yes. Like, this isn't just like, oh yay, empowerment stuff, which I do love. Yeah, but it's also like financially
it makes sense.
We got to put our we got to invest in things that will actually have such a high ROI. Yes. And yet we just don't. La-di-da,
yes. There's so many things there, because also when you're talking about women leaving careers, at that point, because they can't focus, like there's brain fog or, just overall discomfort. You're probably also having so many women who are leaving careers that they love. Yeah. And that also brings them joy in a different way, you know? And so the personal cost and the cost to the world, is really substantial. I want to talk to you because you brought it up before, menopause. And I have to tell you that my initial reaction was like, oh God, they're going to take everything from us. Like, we have menopause. So like, tell me about menopause, because I think that's probably something a lot of people are not familiar with at all.
So I call it menopause. The actual terminology is andropause.
I like menopause.
Yeah. And this actually, that's actually what I first learned. Because as a urologist, we learn all about the male life cycle. Like, we're not just fertility. Like, we also learn, okay, what happens when fertility starts to go away? What happens when we start to age, all of those things. Like that, I think, is something that's very different in terms of a lot of other medical specialties. We don't learn the lifespan. If I'm in a very gendered specialty. In terms of sexuality, we learn the lifespan of a man. And I don't think a lot of, and on the flip side, I don't think gynecologists learn the full lifespan of a woman or someone with ovaries. And how, and not just from a disease state, but from just like, these are things you can start expecting.
Yes.
And so menopause is when men's hormones also start to decline. Okay. And men make all the hormones just as women make all the hormones. This is also a big thing of mine, is that there is a lot of myth, and there's a lot of myth, especially in women's health, and not facts. And so I spend a lot of time on the facts. So when we start declining in our hormones, it changes how we present to the world. Yes. So weight gain, fatigue, insomnia, low libido, erectile dysfunction, mental fog. When men start experiencing that, you know what they do? They come to their urologist and we say, yeah, we believe you. Yeah. Let's check your labs. Yep, totally. Your labs reflect that. Here's medications. Oh, so nice. That's so beautiful.
That's lovely.
That's how I learned to train. And so when I was in my fellowship and I started doing menopause, I would hear stories of like, yeah, you're like the 20th provider. I had to finally just go out of network to get this care. And I was like, wait, what? Yeah. Wait, what? My brain is broken. Yes. And so when I got my first job, I knew I wanted to be able to do menopausal care in an insurance model just to show and prove that it could work. Because of the urologists that graduated from the only fellowship that did this work, most of them went private practice. Okay. And because the system isn't really set up well for menopausal care under an insurance model, and I wanted to prove that it was you could.
Right, because right now some people are getting amazing care and other people aren't getting any at all.
Exactly. Yeah. And I think one of the things, and this is why I actually pivoted into tech, was I got to see a lot of D2C, direct-to-consumer companies doing what we should have been doing in healthcare. Wow. So a lot of the menopausal companies that are out there, the big ones, Midi Health, Alloy Health. One of my new favorite ones is Jayla Health, which this is a menopausal company for Black women. They're saying, okay, yeah, no, we believe you, and we're here to help, because your traditional doctor. And again, doctors are inundated with so much. Yes. We're going to give them a lot of grace. Yes. But
it's the system.
It's overall. The yes and. It's like, yes. And right now people are suffering. Yes. So how are we accommodating for that? We're not moving fast enough. And these companies are already here to deliver that care. Yes. And I think one of the coolest things to me as being like a strategist as well is seeing the reason why a lot of these institutions don't teach this is because they don't value it. Yeah. And then all of a sudden now these D2C companies are making millions of dollars actually giving the care that y'all were supposed to be giving. So they're
like, oh, wait, hold on.
Exactly. And unfortunately, we live in a capitalist society where your value is reflected by your monetary return, your ROI. And so now we're seeing and hearing conversations within these companies. There's also been grassroots movements. Yes. We're now seeing the impact of that, where institutions are kind of being held accountable, or they're going to have to lose patients. Yes. And so that's what I'm excited about, is that you, as Nigerian, I love a coup. I love a little coup. If something is not working, just change it. Yes. And to watch these D2C companies kind of change the game and then force internally the academic side to also start changing.
I mean, and maybe that's what it takes, but hopefully, there is an awakening, that you're a part of, like, in this field. And women, like the more like of the people who came up to you, you know, when you were at Essence Fest, the more that people like, oh, there is a way for me to be believed, to find solutions, to talk to people about this.
Yeah.
You know, that's so empowering too.
Yeah.
So,
Yes.
this has been an amazing conversation. Thank you so much. I mean, I know there's probably 10 other things that we could talk about, but if people want to find out more about what you're working on, including like Vulva AI, where can they find you?
Yes. So I have a private practice in Beverly Hills. You can find me at mariaulocomd.com. You can also find me on Instagram at mariaulocomd. And if you want to follow and find out more about what we're building at Vulva AI, you can find us on Instagram at vulvaai.co. And then you can also find us on our website at vulvaai.co. Please sign up for the waiting list. We're trying to get to 10,000 people by the end of July. Yes. The sooner we get that sign up list amped up, the sooner we can launch. Okay. Our goal is to build a women's health Google, because right now, 50% of what you find on Google is wrong. And we want to be able to empower patients by giving them personalized insights into their vulvovaginal health, which looks like their bladder health, their sexual health, their pelvic health, and even their bowel health, all directly to the phone, so that when they go into the doctor's office, they already know the language. They already know what it could potentially be. They also know how to talk to them, because talking to the doctor can be really scary. Yes. And if you have specific language, if you have evidence-based research, you are now more empowered to make better decisions for yourself.
Yes, that's amazing, Maria. Thank you so much. For more on what I'm doing, you can find me on social media at Therapy with Dr. Patrice. Thank you so much for tuning in, and thank you, Maria.
Thank you so much for having me.